Hello, and thank you for joining us today. I'm Tiffany St. Cloud, the Program Manager for the AAMC's Lesbian, Gay, Bisexual, Transgender, and Disorders of Sex Development Affected Patient Care Project. Today we are joined by Dr. John Davis and Dr. Kristen Eckstrand, who will speak to us on the very important topic of a leader's role in addressing LGBT health in academic medicine. I'm going to give a brief introduction of our speakers, then we will begin the webinar. First, I'd like to introduce Dr. John Davis. John is the Associate Dean for Medical Education at The Ohio State University College of Medicine. He is an Assistant Professor of Medicine in the Division of Infectious Diseases and also serves as the LGBT issue-based representative to the AAMC Group on Diversity and Inclusion Steering Committee. His clinical interests include infections of the immunocompromised host and LGBT healthcare, and his academic interests include professionalism and personal and professional identity development. Next, I'd like to introduce Dr. Kristen Eckstrand. Kristen is a sixth-year MD Ph.D. student at Vanderbilt University School of Medicine with a Ph.D. in neuroscience. She currently serves as the chair of the AAMC LGBT and DSD-Affected Patient Care Advisory Committee and on the board of directors for GLMA, Health Professionals Advancing LGBT Equity, and co-directs the Vanderbilt Program for LGBTI Health. She initiated and leads LGBTI curriculum reform at VUMC and currently oversees medical center-wide LGBTI quality improvement efforts through Vanderbilt's LGBT Leadership Committee and Cultural Linguistics Council. Her efforts at Vanderbilt were recognized in October 2011 when she received the university's annual Levi Watkins Jr. Student Award for her commitment to diversity, and again in 2013 when she received the Distinguished American Medical Association Excellence in Medicine Leadership Award, as well as the AMSA GLMA Medical Student Award in LGBT Leadership. Dr. Eckstrand has presented Vanderbilt's curriculum work at numerous national conferences, including plenary talks at the 2011 AAMC National Conference and the 2013 Gay and Lesbian Medical Association Annual Conference. Dr. Eckstrand's curriculum innovations in LGBTI health have been published in MedEd Portal and in high-impact journals. She hopes to continue to engage in curricular innovations and teaching to further women's and LGBT health. Kristen and John, thank you so much for joining us today.
Thank you very much, Tiffany. On behalf of John and myself, we're both very excited to be presenting to everyone on this important topic. So for today, when we present on a leader's role in addressing LGBT health in academic medicine, we're going to be really providing for everyone here some guidelines for how to empower leaders to ensure LGBT diversity and inclusion by providing a very basic overview of what LGBT terminology means, what the disparities are in healthcare for this very unique population, how academic medicine is currently addressing these issues, and most importantly, what leaders can do to really advance LGBT healthcare at their own institutions. So I'm going to begin by beginning with a very basic overview of LGBT health and terminology. It's important to start with the basics when it comes to terminology because even the terms lesbian, gay, bisexual, and transgender have very complex meanings to patients and other individuals. And then discuss the gaps in academic medicine. John is then going to discuss the role of leadership in administration and then go into some easy wins for LGBT inclusion that we can hope to strive for at our own individual institutions. So when we think about lesbian, gay, bisexual, and transgender populations, I think we all have a general idea of what it means to have a lesbian, gay, bisexual, or transgender identity. But clinically speaking, it's important to take a step back and think about what these concepts mean to a patient. And in that setting, we have to think about three things. We need to think about identity, attraction, and behavior. So identity is at the core how a person identifies themselves. What words do they use and what do those words mean to that individual person? Beyond that, we think about how an individual can relate to the people around them. Specifically, emotional and sexual attraction, are those same-sex or opposite sex? And behavior, how do you interact with the people around you? sexually, emotionally, and also how do you interact with the healthcare profession to achieve your own goals related to your sexual orientation and expression of your gender identity. So a quick example of, when we think about gender identity in particular, it's important to think about the differences between sex and gender as well. So these terms can be used interchangeably, but it's important to recognize that there are some distinctions. Specifically, sex is the biology and anatomy that determines if a person has a 46XY karyotype. Are they quote-unquote male or 46XX quote-unquote female, or another karyotype that may lead someone to identify as male or female. These are things that are biologically and anatomically determined. But gender is a much more complex overlay on the idea of sex, and that's a culturally defined concept that incorporates physical, biological, mental, and behavioral characteristics that we then ascribe the term masculine or feminine to. And sometimes sex and gender are concordant with one another. Sometimes we would say that they might be discordant, or they're just a natural expression of one's own identity. So how we think about these things for sexual orientation. So sexual orientation is really one's emotional and sexual attraction to other individuals. With respect to identity, this can be as simple as saying lesbian, gay, bisexual, straight, or another term that an individual might use, such as queer. Someone could be questioning what this identity might mean. And then there's attraction and behavior. So individuals who are lesbian may have same-sex attractions to other women. They could also have opposite-sex attractions but still identify as lesbian. And then behavior is also another overlay, is that even if someone identifies as part of the LGBT spectrum, they could be having emotional or sexual attractions or relationships with people outside of what the terminology might dictate. So for example, lesbian and bisexual adolescent females actually have higher rates of unintended pregnancy than their heterosexual counterparts. So it's important to think about how identity is something that's important to the person, but how we still need to think about their attraction and behavior and how that relates to the health care that they need. With respect to gender identity, that's really a person's sense of their own gender. And again, we can think about how this relates to identity and behavior. So when we think about identity, someone could identify as cisgender. So cis, if we go back to chemistry, we think about same side. So their gender identity is concordant with their born sex. Or someone could identify as transgender. So their gender identity is different from their born sex. And common terms that you often could hear are NTF, so male to female, or transitioning to female, or female to male, or FTM. These are very discrete terms, and people may choose to not identify with a gender and identify as genderqueer. But again, this terminology is very important for a person, and it's important that as clinicians and providers, we know what exactly that terminology means to someone. Knowing that, we can start to think about how we can help an individual use medicine to achieve an identity and physical and emotional appearance that is consistent with their gender identity. So when we think about what types of things we can do medically, an individual themselves may have their own gender expression, but may be thinking what they may want to do with certain hormonal interventions to have the secondary sex characteristics of a certain gender, or surgical intervention as well. And these are things that we can do regardless of whether or not someone identifies as transgender or cisgender. There are always surgical or hormonal enhancements that we use to promote someone's own sense of self related to their gender identity. And so sexual orientation and gender identity are therefore very diverse concepts that extend beyond these discrete labels that they're often given. And when this happens, we make assumptions, and that these assumptions can then alienate a patient from connecting with their provider, and it enables a provider to give less than optimal patient-centered care. So some common assumptions that you see related to LGBT individuals is, first and foremost, heterosexuality is often assumed. Sometimes this is assumed because we make assumptions on someone based on their appearance. Do they look gay? Do they look straight? We also make assumptions that sexual identity is based on behavior. So if someone is having sex, if a man is having sex with other men, he must be gay. But we do know that a lot of men who identify as heterosexual do have sex with other men. Another assumption that's often used is that patients use traditional labels like lesbian, gay, or bisexual, when really there is a spectrum of labels that people will use. And it's important for an individual to have an opportunity to disclose the term that they use to identify themselves. And as providers, it's important for us to know what that label means to them and how they relate to other people. Other common assumptions are that gender identity is equivalent to sexual orientation. So if someone is transgender, we can then make an assumption about their sexual orientation and the behaviors with other people that they engage in. And so all of these assumptions do serve to alienate the LGBT community from care. And we do know now with a number of monumental reports that have come out over the past decade that LGBT individuals do face health disparities with respect to accessing care, health care outcomes, and treatment of certain diseases, which I'll go over in the next slide, as well as cultural barriers to care. So thinking about how a double minority status, racial and ethnic minorities, religious minorities who also hold an LGBT identity. These are very important concepts that can exacerbate the disparities in care. We also know that medicine contributes to these disparities, sometimes through a negative environment with bias and discrimination when accessing care, a lack of appropriate education of students, but also of faculty, staff, and other individuals within the healthcare setting, limited outreach and advocacy to the LGBT communities in which academic medical centers are located, and then also pathologizing identity. So a great example of this is that up until recently, individuals who were transgender or gender nonconforming could be given a label of gender identity disorder, when really one may not have a disorder. They may experience challenges as a result of having an identity that may be secondary to environmental circumstances or the process of having to go through a certain change like hormone replacement therapy. These things are certainly expected from having a transgender identity, but that doesn't necessarily mean it's a disorder. So, and homosexuality was removed from the DSM in the late 1900s. So up until recently, an LGBT identity in and of itself was pathologized within medicine. However, it's been a very exciting time over the past 10 years where the importance of LGBT health disparities and promoting the health of this community has garnered national support. Presidential executive orders to allow for equal visitation rights for LGBT families. The Joint Commission has promoted standards for advancing effective communication, cultural competence, and patient and family-centered care for the LGBT community. The Affordable Care Act also allows for all LGBT individuals to access health insurance, and other national organizations have begun to promote improved research around truly understanding the disparities faced by the LGBT community. And when I talk about LGBT health disparities, it's important to think about how these disparities both come in the form of health outcomes, but also in terms of accessing care. So some examples are that LGBT individuals are at a 3 to 7 times increased risk for suicide, and 10% of the LGBT community reported attempting suicide in the past year. They're also at increased risk for obesity, cardiovascular disease, and certain types of cancers. And we have to think about these health outcomes as they relate to the lifespan, how it affects children and adolescents versus the elderly, and how these outcomes are affected in individuals in rural communities, lower socioeconomic status, if they hold another minority status. When we think about accessing care, up until the Affordable Care Act, LGBT individuals were 2 times more likely to be uninsured. And just when accessing care alone, 56% of lesbian, gay, and bisexual patients and 70% of transgender patients reported experiencing bias and discrimination with accessing care. And again, these are exacerbated in minority, rural, and lower income LGBT patients. When we think about what the environment is currently like in academic medicine, a majority of the work that has been done has been related to medical education. So a great study that came out in JAMA in 2011 looked at what were the primary topics discussed in undergraduate medical education as rated by deans of medical schools. And what you can see here, up here in green, these are the topics that were most commonly discussed. So sexual orientation, gender identity, HIV, and STIs, and safer sex. So really what this is saying is that we talk about definitions, we also talk about sex-related behaviors. But when we think about the things that place a disproportionate burden on the community that I just mentioned, coming out, substance use, chronic disease risk, transitioning, these topics are poorly taught, and they're listed down here in red. Faculty have been surveyed to think about what are the barriers to including content and educating future providers. And of course, a big one is lack of instructional time. But there are some other things too that are particularly telling. So a lot of people cite a lack of relevance to their course content. I think this is an important one because it really shows, if you look at that list from the previous slide, there is an opportunity to integrate LGBT health in every academic medical course. And this really gets at the role of, are we making sure that we have the appropriate faculty members to teach LGBT health, and are they trained to do so in a sensitive and inclusive way, which goes into a lack of professional development on this topic. The JAMA paper that I mentioned earlier also listed a number of strategies that could potentially be successful in increasing LGBT-related content in curricula. And what Dean said at this point is that developed curriculum material focused on LGBT health would be extremely valuable because there is limited content out there. And we'll talk about this a little bit later on about where some of these resources can be found. But faculty willing and able to teach LGBT-related curricular content is also important. So ensuring that institutions prioritize LGBT health and the development of their faculty to be able to teach this content is certainly important. And again, more time and certainly improved evidence are other opportunities as well. When we think about education, we do know also that education does not occur in a vacuum. It occurs in a climate that can promote the awareness of LGBT health issues, and they can also make it challenging for LGBT medical students to obtain a degree or thrive in medical school. And recently, in 2013, AAMC began to look at what the medical students identifying as LGBT were experiencing within academic medicine. So looking at the thoughts of second-year medical students, what we can see here is that lesbian, gay, and bisexual medical students experience increased stress, increased social isolation, decreased social support, and a decreased emotional climate. What this really says to me is that the climate within academic medicine is no better than the climate existing in the general community, where you do have this increased social isolation and decreased social support. And while we have this information on students, the experience of faculty, staff, and patients within academic medicine is likely to parallel that of students. Again, getting at this idea that even if we add content to the curriculum, we have an underlying environment that is particularly challenging for any LGBT individual entering academic medicine. So the important question really is what the role of leadership and administration is in promoting LGBT inclusivity. And I'm going to go ahead and let John talk about that.
Great. Thanks, Kristen. So I think for all who are here, Kristen did a great job of summarizing a lot of information actually, and really outlining some of the disparities here. I'm going to make the assumption that we all are able to act as leaders in one form or another, in whatever capacity. And so I think the questions that fall to us all as leaders or as administrators is, first now, how do we know what to do, and where do we look for some kind of guidance in terms of where to go? Let's see. Okay, so the first and I guess the most important thing that I want to mention throughout this talk is it's really about engagement. So it's really about asking the questions, about thinking about LGBT health when you're otherwise participating in your leadership or administrative role. So from a microscopic perspective, looking at what is under a particular leader or administrator's purview, it's about thinking about your policies, getting to know them, and then starting to examine them from the LGBT lens, and then starting to look at metrics. If we have policies that are inclusive of LGBT constituents, how are we measuring enforcement of those policies? From a macroscopic level, sort of outside of one's own leadership or administrative purview, it's really about asking more questions. It's about making sure that we are all held accountable for making care better for our patients and making an educational experience better for all of us. So I like to approach much of the dissection of the role of leadership and administration from three different perspectives. First of students, then of schools, and then of systems. So for instance, now before I launch into this, I really hope that this will serve as kind of a resource for a lot of people, and I've given here some references about some of the guidelines and policies. I'll touch on some of them, but for more, I hope that you'll be able to read some of these, particularly where some of the guidelines might resonate with your areas of leadership or administration. So within student education, some of the questions that might naturally fall would be, how do we approach LGBT diversity in medical student education, and how are we teaching our students what they actually need to know in order to care appropriately for LGBT patients? And so, three sort of easy ways to start with this. One is the physician competency set that was published by Bob Englander and others in academic medicine toward the end of last year. And in particular, there are several competencies there that deal with LGBT either directly or indirectly. I reference here 2.5, which is really about the impact of cultural influences on the provision of care. 4.1, which is really kind of about communication. And 5.5 very explicitly deals with LGBT aspects, which is demonstrate sensitivity and responsiveness to a diverse patient population, including but not limited to diversity in gender and in sexual orientation. Competency 7.1 is really about teamwork and establishing a community and a feeling of respect and diversity on the team. So again, you can see how any of those might be viewed through the lens of LGBT to help look at how we're actually doing in terms of educating our students. Another way that we've been looking at is through entrustable professional activities, and that's available on the iCollaborative site of MedEd Portal. And I reference here EPA 1, which is about gathering a history and performing a physical examination, because that really then deals with a lot of the competencies that are needed in order to interact with an LGBT patient, for example. from a communication standpoint, from a fact-finding standpoint, and from an examination standpoint. And EPA 9, which is about contributing as an integrated member of an interprofessional team. Again, getting to the competency 7.1 about how do our students learn how to maintain a culture of dignity and respect. And we actually have metrics to then look at. From the student education standpoint, a graduation questionnaire is administered to all graduating fourth-year medical students. And in particular, looking at questions 13 and 15, one of the aspects of question 13 asks students to evaluate whether they thought their instruction in culturally appropriate care for diverse populations was inadequate, appropriate, or excessive. And question 15 asks their level of agreement with the statement that they are confident that they have the knowledge and skills to provide safe-sex counseling to a patient whose sexual orientation differs from their own. So these are easy ways to figure out how students are viewing the educational experience they're going through. From a School of Medicine standpoint, now focusing a little bit larger, some of the questions that might fall would be, how do we approach LGBT inclusion from the school and college level? How do we know our institutional climate is appropriate? And so here I now reference the LCME document, Functions and Structure of a Medical School, and I've included some of the standards here as a reference so that way you can go back and have a look at those. But for instance, under the curriculum, there are several standards, ED-10, which is really about behavioral and socioeconomic subjects that includes topics such as human sexual and gender development, human sexuality and sexual functioning, but also health disparities and cultural competence. And ED-21, which has to do with more education on cultural competence, and ED-22, which has to do with making sure that our students can recognize and appropriately address gender and cultural biases in themselves and in others. From a climate standpoint, MS-31 and 31A are kind of considered together, where MS-31 is really about that our medical students should experience no discrimination on the basis of age, creed, gender identity, national origin, race, sex, or sexual orientation in any of the program's activities. So again, that policy explicitly includes gender identity and sexual orientation. MS-31A is then a follow-up on that to make sure that we are really providing an optimal learning environment for our students that explicitly promotes the development of appropriate professional attributes. And MS-8 and IS-16 are often considered together, where MS-8 is about developing programs aimed at broadening diversity among qualified applicants for medical school, and IS-16, which is about policies and practices to achieve diversity among students, faculty, and staff, and other members of the academic community. So again, those are written policies that are in place that we can use to look at how a School of Medicine might be functioning to see if we're actually up to standards. At the same time, it's worth noting that the LGBT and DSD-Affected curriculum is present, so there are curricular competencies and how we might go about integrating competencies within a curriculum. And then from the graduation questionnaire standpoint, again, we have another question 42, which is really about getting at MS-31A, about the learning environment, and asking about student mistreatment. And one of the aspects that they ask about under student mistreatment does involve sexual orientation, and it asks students very explicitly if they feel they have been denied opportunities for training or awards based solely on sexual orientation, and also asks if they have been subjected to offensive remarks or names related to sexual orientation. So again, these are policies that are already in place that we can use to look and see how we're doing. And then from the medical center and hospital standpoint, again, the question is how do we approach LGBT diversity and inclusion there? And luckily, we have a lot of guidance available from the Joint Commission statement, which is on the left, and from the Healthcare Equality Index I've pictured on the right, and both of those are referenced at the very end of this talk. So I think all of these are some resources, and again, we'll talk more about resources toward the end. But basically, now that we know sort of what some of these policies might be, how do we go about implementing things? So in terms of easy wins or maybe some next steps, what are we doing for LGBT health in our areas? And what could we be doing for LGBT health in our areas? So starting with some of the fundamentals. So looking at employee or patient non-discrimination policies. Is sexual orientation included there? Is gender identity and or expression mentioned explicitly in those policies? What about visitation policies? What about decision-making policies? Are those comprehensive and inclusive of sexual orientation and gender identity? And then if policies are in place, how do we know that we're complying with them? Are there methods for assessing that compliance with reporting and handling of policy transgressions? Do we have a way to seek input from experts? Is there, for instance, an LGBT advisory committee? Or is there a voice from the LGBT communities at the decision-making table to help support that across the institution? From the faculty and employee standpoint, what about domestic partner benefits? In particular, in some states where rights are not otherwise guaranteed, those can be very, very important. What about a recognition of family? Do we have an explicit statement in place in our workplace that recognizes a family with an equivalent to spousal benefits, including sick and maternity leave, tuition remission, et cetera? What about insurance coverage policies? You know, for instance, are transition-related care expenses covered under insurance? For our hiring policies, are we looking at things like how do we ensure diversity is considered when hiring employees? And in particular, how do we consider LGBT status in that decision-making process? Do we have LGBT advocates identified from who can help across the medical center and from human resources standpoints? One thing that several medical centers have put into place is an LGBT employee resource or affinity group, and they've found that that can be very helpful in satisfying a lot of the easy wins that have been mentioned so far. What about from the student's standpoint? Is there a way that faculty and others, and even other students and their colleagues, can visibly support LGBT diversity? Are there LGBT-specific support services? What about methods to share LGBT status on an application? And then what happens if a student does? If a student does, do we have some way in place to allow them to connect with our LGBT medical student group or others? Do we have a way to consider LGBT status if a student chooses to disclose that? Do we have a way of considering that as part of an admissions decision? In terms of hospitals, what about LGBT inclusive materials in hospital rooms, in waiting rooms and waiting areas, et cetera? What about gender neutral restrooms? How about clinic and intake forms, and that includes when patients are admitted during admissions? Do we have LGBT status identified there, and do we allow for people to identify the people who are important to them in their lives? In terms of clinical decision-making technology and tools, does our EMR support things like asking for a patient's preferred gender identity? And what about their sexual orientation? So just asking some of these questions can be very helpful. For our LGBT youth, do we prioritize their confidentiality and allow them to feel safe in coming out and talking about different aspects of their health? Do we have education on this present for our students, for our faculty, and for our staff? We spend a fair amount of time talking about curricular aspects, but at the same time, what about for other faculty and staff? That can come in the form of safe space training, but there are other ways of doing this as well. And then do we have ways to promote the visibility of clinicians who have an LGBT practice focus? Are we engaging with the LGBT communities at large so that we can provide better care to them? So I'll pass things back over to Kristen to discuss some of the other resources that are available.
Thanks, John. So I think first off, we can think a little about what is actually available from the AAMC. And of course, the AAMC, the GDI, diversity policy and programs, these are all sort of large resources that are available to you and have people that can answer your questions or point you in the right direction. Some of the sort of finer aspects of what's available from the AAMC, of course, John mentioned the MedEd Portal project. So MedEd Portal has a collection of LGBT health and disorders of sexual development affected materials that are available. And we encourage submission of any materials that you have developed as well to be able to enhance this resource sharing. In terms of what's available for the curriculum, the AAMC LGBT and DSD-Affected Patient Care Advisory Committee has put together a list of competencies that span across undergraduate medical education, things that span knowledge, skills, attitudes, and behaviors that medical students should have to be able to provide comprehensive, inclusive, and sensitive care for LGBT individuals. The AAMC also has health equity research and policy, and a group on faculty affairs as well is also a great resource from the AAMC. When we think about academic medicine in general, one of the most exciting developments that has happened in the past decade is that a number of academic medical centers have developed these LGBT-specific programs. In addition to the program at Vanderbilt, the George Washington University now has a specific LGBT health graduate certificate program that's 1 year that people can enroll in to learn more about LGBT health and how to become more engaged in promoting equity within the LGBT community. Beth Israel also has a patient care focused program, and the University of Pennsylvania additionally just established its own program to promote LGBT health across its academic medical center. So these are all programs that you can contact to learn a little bit more about how they were established and what their role is in promoting LGBT health across the institution. Outside of academic medical centers, there are a number of national resources that have really helped to drive progress within the field of LGBT health. John mentioned the Healthcare Equality Index. This is a wonderful resource that provides a checklist and can be really instrumental in accelerating change within your institution because if institutions meet certain criteria, they are designated as a leader for equality, and that can be a great milestone for academic medical centers. The Joint Commission report on advancing effective communication, cultural competence, and patient and family-centered care, again, also provides a wonderful checklist. And for individuals who would like a more evidence-based foundation for health disparities, the Institute of Medicine report in 2011, The Health of Lesbian, Gay, Bisexual, and Transgender People, can be an excellent evidence-based resource for promoting change. GLAMA, Health Professionals Advancing LGBT Equality, also has wonderful resources. And the Fenway Institute in Boston has a number of webinars that you can listen to on a regular basis, a number of resources available for providers as well as educators. John and I are also more than happy to answer any questions now, as well as by email later on to help you achieve your goals at your own institution. So we will go ahead and start answering some questions. And I think first and foremost that there have been a couple of questions on whether or not these slides will be made available and links to resources. So these slides will absolutely be available. If there is a resource that we have mentioned that you are unable to access, please feel free to contact either myself or John or Tiffany St. Cloud from the AAMC. The first question that was asked was looking at the different acronyms that we've used. So the question was, different acronyms are used to describe LGBT populations. Is there a standard endorsed by the AAMC we should be more inclined to use? So LGBT, LGBTQ, or LGBTQI. So in this talk, we've really focused on LGBT. The other population that we have not discussed in this talk but will be addressed in subsequent webinars are individuals affected by disorders of sexual development. The acronym that we have used currently at the AAMC is that we are now using LGBT and DSD-Affected, but we also support schools using broader terminology if they feel that's appropriate within their own institutional goals, if they feel like they want to include Q for queer or questioning. But as of right now, the AAMC is using LGBT and DSD-Affected. The second question I'm going to let John handle. The policies that you initially discussed, John, are these policies for hospitals or for medical schools?
Right. So I obviously went through quite the litany of policies there, and I've tried to make them a little bit more specific in terms of where I discussed them. So on some of the slides where I was talking about medical school or curriculum, an MD curriculum, that's where I've tried to bring up ones that were really relevant mostly or only to those venues. So I'd say from a hospital standpoint, the most important ones that I mentioned were the JCAHO document and the Healthcare Equality Index. But otherwise, yeah, there can be quite a few. So I'm hoping that for some people, some of these will resonate, and so for people who are otherwise involved in the curriculum at their respective institutions, that some of these can be useful for other curricula as well. But that's where we tried to go with that. And then I guess another question I was going to say, so I see that there was one question about how to deal with the argument from medical school faculty and leaders that we already address LGBTI issues, especially in the face of the fact that attention to LGBT issues is pretty minimal and in some cases superficial. So, and I think as Kristen nicely pointed out before, there's still this fight going on in the curriculum for time in the curriculum, et cetera. So I think one of the things that we can do to address that is really look at competency-based education. So again, having mentioned some of those competencies before, we can look to see, are our medical students or other learners developing the competencies or displaying the competencies that we would expect for them to provide appropriate care. So it really is not as much about, do I have X many hours in the curriculum, at least from my standpoint. It's more about, are we doing what we need to do to allow learners to achieve those competencies? And so if there are metrics that we use that say that our students don't develop them, then that's, I think, a very effective argument to say, well, we clearly need to do more here, regardless of how much time we're spending, whether that's a lot or a little, we need to do more to help our students develop, if that helps.
Yeah, and John, I also think it's important to mention here that it's very difficult when there is limited research available to show that there are deficits. So I think our first question to ask is, when someone says that they already address LGBT issues, I would ask, how do you know that what you're doing is effective? If they don't have data to show that it's effective, I don't think it's fair to say that you are covering it appropriately. However, if you know that what is being covered is minimal and superficial and doesn't truly address the depth of LGBT health in academic medicine, what I would strongly do is encourage you to think about how you can start to collect some of that information on your own. So what a number of schools have done, and certainly the MSQ is the foundational tool, and a report from the AAMC will be coming out in 2014 that identifies those disparities for LGBT students. What other schools have done is taken it upon themselves to pull together small evaluations of institutional climate or an institutional curriculum, academic curriculum, or survey medical students to say, how comfortable do you feel with handling LGBT patients? A lot of medical students will actually openly acknowledge that they don't feel as comfortable, and when they're asked to provide resources for their, where would you send an LGBT patient, do you know where you can point someone in the right direction? Who would you refer someone to on this campus? They would say, I don't know. So I would encourage you to think about what small steps for data collection you could do to demonstrate the point that you know is true, which is that there needs to be more. I think the next question is from Desi Ehrenfeld, which is, are there any exemplars in the GME space on teaching LGBTI health? This is really can be a bit of a challenging question. Certainly a number of the medical organizations like AAFP have put in place GME guidelines for what should be covered in a curriculum. ACAP as well has put forth guidelines. The pediatrics, the American Academy of Pediatrics has also put forth guidelines, but whether or not these are actually effective, I'm not aware of any tools in order to assess that or data that has come out. I think from a standpoint of what can be generally available is even to take the LGBT and DSD-Affected Patient Care Advisory Committee competencies, because those really do extend across the learning spectrum, and to think about how we can place those into milestones that extend into GME. Certainly that does place more work, again, on people who are committed to this, but that is a good first step. John, do you know of any additional resources within GME?
No, Kristen, I think you're exactly right. So I think the real focus has to be on looking at the milestones here, and in particular as the Milestones Project rolls out for ACGME, making sure that, that some of the ones that have been elucidated for medical school education are also incorporated. So that way we're all speaking the same language, and that way we can ensure that if someone makes it into a graduate medical education program, but still may be deficient in a couple of areas or not have met competencies in certain areas, that we measure those and demonstrate those and have remediation efforts in place.
So the next question is from Stacy, who said, I have the opportunity to meet with a vice dean of our medical school about LGBT inclusion in the curriculum. He is supportive but unclear on where to start in an environment that is generally overworked and struggling to already fit it all in. Where should you start when you have your conversation with him? I honestly think that question that John mentioned early on, which is what am I doing and what can I do, that is such an important question. I think for all of us who are knowledgeable in the field of LGBT health, have an idea of where we would like things to go, and sometimes it can be really challenging when things don't go as fast as we would like them to go. I would strongly encourage you to think about what the small steps are that you can take to be excited about. So we can also think too about how, when we think about LGBT identity, how does that overlap with what you're already doing with certain teaching tools? So a number of schools are using standardized patient cases. Can you adapt those cases in a way to say, well, you have a patient, can you add in LGBT identity and add a question that may relate to that? Because I think it's challenging when people think that LGBT health needs to be in this completely separate realm, when many times LGBT patients are coming in to academic medical centers for the same health concerns as other people. So how just providing the experience for a student to work with an identified LGBT patient challenges students to think about how they react, how they could do things differently, and that actually improves their interactions with LGBT patients in the clinical setting. So what I would strongly encourage you to do is think about what the next small step could be that doesn't disrupt the curriculum by just adding a small LGBT component to an already established curricular innovation. And that's what a lot of schools have done nationally. I think the next question that is coming up here is, let's see. So the first step is attending this webinar to educate ourselves. We have a question from a registered nurse and is wondering how they can, what first steps you can take to open up a conversation with the hospital administration to become more inclusive. John, do you want to start with that one?
Sure. I mean, I think so. One of the things that can be helpful is to determine who your supporters are first. So making sure that you identify senior leadership in, for instance, in hospital administration to see who's receptive, and then understand what the other normal mechanisms are for incorporation of diversity and inclusion principles and policies into otherwise broader hospital policy. So if you have those things in mind, then I think that's usually an easy way to start. For instance, at our institution, we developed an affinity group as well that also had a seat on a diversity body that then allowed us to start different processes. One of the easy things that we were able to do was to at least start participating in the Healthcare Equality Index. And that is an external source of benchmarking that many people in the hospital are willing to listen to. And, you know, at the same time, you know, JCAHO itself carries a certain amount of clout, and so when they release a document such as their own guidance document on LGBT healthcare and policies, that can be extremely helpful as well. So I'd say those are two sort of easy things to do. First, identifying, you know, who your supporters are, identifying how diversity and inclusion have been dealt with otherwise, and then sort of using, you know, leveraging some of those pathways to then see if you can participate in things like the Healthcare Equality Index, because that actually does cover some of the things we mentioned before, like, you know, inclusion policies, et cetera. So I'd say that's a reasonable way to start.
Tiffany also asked me to elaborate a little bit more about how we got to where we are at Vanderbilt. So I will say that what we have at Vanderbilt right now, we now have, we were the second program in the country to establish a program for LGBT health that reached across our medical center. So the way we got there was, and again, this is one process that has been used. I'm going to send everyone a link in the chat box to a video that was produced by the AAMC a couple years ago that spoke specifically about the process that we used. So the change process really began with students at Vanderbilt noticing that they wanted more information about LGBT health. And we got connected with a staff member, the Dean for Undergraduate Medical Education, who was willing to help us develop a project that would be valuable. And she put this in a context of change management. And I think that change management is one tool, but a very helpful tool for Vanderbilt to really continually evaluate where we are. So the idea within change management is first and foremost to establish your need for change. What is it that you really truly want to accomplish? The next step is again to build your team. Who can help you move that change forward? Then design and innovation. What can you do to help with that? Implementing it, but then also evaluating it. So for every single small thing that you do, make sure you have data to say that what you did worked, because that will continue to show that your efforts are successful. And so this video highlights that process. But the way that it worked at Vanderbilt is we decided to survey faculty members about LGBT content inclusion and whether or not they felt like we were doing a good job. And in that survey, which was anonymous, we allowed faculty members to say, here's my name, and I am willing to have my course revised to include LGBT content. And so we had a group of students and a faculty member who helped us go through and look at the content within each of the courses. We had about 7 or 8 courses that spanned about 50% of our curriculum to say we'd like to include more LGBT content. And so over the course of a year, we integrated content into the curriculum. And when we did that, we collected data to show that it was working, and there are success stories on MedEd portal from Vanderbilt on what we did. But then also that garnered the attention of the administration and allowed us to then bring participation in the Healthcare Equality Index to Vanderbilt. And that really encouraged Vanderbilt to think about their policies and practices because they wanted to be a leader in LGBT health. And I think that that last point is also extremely important, where you need to institutionalize diversity in a way that people are thinking about how do I promote diversity in all forms across the institution. And so continuing to demonstrate to administration that this needs to happen. That's the process that we took at Vanderbilt, and it took about 4 years for us to establish our program. So it's a long process, but with dedication and continued improvement, slow, steady progress, we eventually got to the point where we're at now, and we certainly have more room to improve, but using change management was a very helpful strategy for us. So the next question, let's see, Chiquita Collins mentioned that Georgetown University is quite resourceful with various assessment tools and other resources. Would we recommend for academic medicine or any resources available in Spanish or other languages? So the Georgetown program is a wonderful program led by Stephen Forcell, who has really done great work. And I would encourage everyone to take a look at what they have to offer. So I'll just flip back to the slide right here. The LGBT Health Graduate Certificate Program, they offer a great curriculum for how to think about LGBT health. And I would strongly encourage, and the AAMC would encourage everyone to take a look at that when you have the chance. Let's see, the next question from Tiffany. How can we learn from the institutions that are holistically teaching LGBT health disparities without reinventing the wheel? John, do you want to touch on that one?
Well, right. So I think one of the things that might be helpful is, number one, the contacts that you have listed there. So again, and I think Kristen and I both are able to act as contacts to help guide you, because there are many institutions that are also developing or have developed LGBTI programs or other resources, and a lot of it has to do with what any individual program might need. In particular, I will say as well, one of the questions that came up was about resources available for faculty who want to teach content but may not have training or education in LGBT health. I would say, as an example, the Fenway Institute has done a great job of posting some of their PowerPoint slides and other videos online, so those are able to be used. At the same time, there is at least one textbook out, the Fenway Guide, and there are others that are forthcoming. So I think there are lots of resources, and there are a growing number of resources that I hope that many centers can use to help determine what might work best for them, and to be able to hopefully import them without, as we say, having to sort of reinvent the wheel there. So it does not necessarily require expertise in these areas. In some instances, as one of the other questions had come in some instances it is a member of the LGBT community who's selected to do this. or who volunteers to do this, but at the same time, it does not require that expertise in order to ask those key questions. So I hope that comes across.
I also forgot to answer the second part of that last question about recommendations for resources in Spanish or other languages. I think that is such an important question, and it's something that some places have done well, and there's certainly a ton of room to improve in that area. The first place I would point for Spanish resources, Spanish-speaking resources, would be the Fenway Institute. Many of the materials that they have available are available in Spanish. When we think about some of these other national programs, another great program would be the Family Acceptance Project that's based out of California. Their resources are also available in Spanish, but this is particularly a challenging area. So what I would encourage you to do for Spanish-speaking resources is start with the Fenway Institute and start with the Family Acceptance Project, because those resources are available in Spanish. They may also be able to point you in the right direction for other Spanish-speaking resources. The next question is, what resources are available for faculty who want to teach this content but don't have training or education in LGBT health? This is a really great question, because it gets at this idea that when an institution isn't prioritizing diversity or the degree to which it should be prioritizing diversity, the burden really falls on faculty or students to educate themselves in the area of LGBT health. And again, I don't think the slide that we're on right now, right here, this is sort of your toolkit for development, faculty development. So first off, again, the Fenway Institute offers online webinars. Not only are they related to LGBT health, but you can also get CME credit for those talks. So that way, the time that you spend, you get something back from that time. GLAMA is also beginning to offer webinars, and they're working towards CME credit. Those two places are really great, and I think it's also just keep an eye out from the AAMC, as they're also working on producing a video series about LGBT health as it fits within academic medicine. If you have the time to do more extensive reading, probably the best places to better understand LGBT health is really this Institute of Medicine report. That is the best, most succinct, comprehensive literature review available right now for LGBT health. And they have it broken down into into really sort of a lifespan approach. What are the needs of children, adolescents, adults, elderly, and looking at some of the nuances with healthcare in those different populations. But if you're looking for sort of a targeted topic, you can certainly look within the index, and if the topic's available and important to the LGBT community, it will be mentioned in there. Let's see. Next question is, how does the MedEd portal and LGBT and DSD-affected health collection interface with this work? How easy is it to submit? And if you have submitted, can you discuss your experience? So MedEd portal is really a wonderful tool for information sharing. And they have 3 different venues in which you can submit information. There's the MedEd portal publications section. That is a section that goes under peer review. And if you have data and outcomes that you can share, those are certainly very helpful. But that's within the publications section. They also have 2 other sections that aren't quite as rigorous to submit to that allow for information sharing even if it hasn't been evaluated to the same degree as a publication might. So the first section is iCollaborative. That's a great resource to be able to share non-peer-reviewed resources. And then the last one is the CE directory. And that's essentially activities that are available for continuing education credits. So MedEd Portal itself offers a wonderful opportunity to submit and share peer-reviewed, non-peer-reviewed, and continuing education resources. The submission process itself is much like any other publication. You can submit online. It's a very easy process, and particularly if you're submitting something that's not peer-reviewed, it's a great way to show and highlight what you've done, and these are resources that are downloaded and used across the country. The next question is, are there a list of training inexpensive opportunities that we can provide for faculty and students beyond the Safe Space program? John, do you want to touch on that one?
Well, right. So I believe there are several different options for that. So first of all, Safe Space training it doesn't have to be necessarily a facilitated thing. But I guess the other thing I'll mention is I believe the Fenway Institute still has trainings that they can do remotely. And so those are options for bringing in people to do training in that way. At the same time, developing even, and this gets back to what Kristen had said before, you know, it doesn't necessarily have to be a standalone thing. It doesn't have to be an involved thing. Sometimes it can just be about infusing certain aspects of LGBT healthcare, et cetera, into existing resources. So for instance, from a hospital standpoint, are the computer-based learnings, if there are any, or the retraining learnings that go on in hospitals usually annually, do those include LGBT healthcare aspects? So sometimes those things can substitute for safe space training or can help promote diversity and inclusion from an LGBT standpoint that don't necessarily require dedicated time out and training, et cetera. And then at the same time, there are asynchronous methods. So again, we talked about the Fenway Institute and some of its modules that it has available. You know, I'll mention again the MedEd portal that allows, you know, that Kristen was just talking about, that allows serves as a repository for some of this information. So it's a great way to share. And so being able to go on there to download, for instance, standardized patient cases or things of that nature, so that, again, you don't have to reinvent the wheel. You don't necessarily have to call everyone together for a safe space training and take time out of someone's day or everyone at once and create a logistical nightmare. It can be about really, you know, how do we piece things together and allow people to satisfy those learning objectives in an asynchronous way.
Yeah, and John, just to sort of piggyback on that, I think that for a lot of schools, I know that this is true of where we are at Vanderbilt in Nashville, there are community resources available for LGBT individuals, and those community resources, reaching out to them and thinking about how they may be able to help with training or how they might be able to help connect you with people who are willing to come in and do a patient panel. I know at Vanderbilt and other medical schools, what they do is they work with community organizations and have contacts with patients who are willing to come in and speak about their experience. And in that setting, it's essentially a free opportunity to hear a patient's story. And if a lot of those individuals are willing to come and talk with students, they're also willing to come in and talk with administration. And the sharing of those stories has been sort of very valuable, particularly when you can ask the speakers to come in and say, you know, what are the top 4 things that a provider should ask the patient related to LGBT health or things like that. We've had a lot of success at Vanderbilt with that technique, and I know other schools have as well.
Right, and I would say as well, don't be afraid to reach out to other institutions of learning. For instance, you know, we're fortunate enough here to have a large undergraduate institution, and sharing resources with them has been great. And at the same time, you know, they're willing to come work with us. You know, sometimes leadership in this can come from other student groups, so from either student groups on an undergraduate campus, or sometimes it's the student group in the medical school, for instance, who can help lead some of these efforts as well and coordinate some. So, yeah, so I think there are lots of opportunities there.
Are there, we're happy to take any additional questions. It looks like right now we don't have any questions that haven't been answered, but John and I are both happy to stick around for a few more minutes and answer some more questions. We are also happy to answer questions by email, or feel free to contact the AAMC LGBT and Patient Care Advisory Committee. We can answer questions that way. But we have both been so excited that everyone attended. Okay, we got one other question about MedEd Portal, about what types of materials can be submitted. So I think that's a really good question because it gets at what people think is a successful innovation. And the materials that have been submitted to MedEd Portal can be anywhere within the realm of academic medicine. They can be related to faculty development. They can be related to institutional climate. They can be specifically related to education. The materials, for example, that Vanderbilt has submitted have been related to medical education. So we had a standardized patient case that we revised to have a lesbian patient instead of just a heterosexual female patient. We merely changed the sexual orientation of the patient and then submitted that case for people to use, and that's been adapted at a number of institutions nationally. Other materials that have been submitted have really looked more at institutional climate and how to make institutional climate more friendly. So I think that the breadth of materials that can be submitted are phenomenal, and they don't just have to be a PowerPoint or a standardized patient case. They don't have to be lengthy. They can be a poster. So we've had posters that have been submitted to iCollaborative, and those have also been really helpful for people. Let's see. The other thing I think that's important to mention would be that these materials that are submitted to the publication, they can be used, you know, when you submit them. Sometimes because it's a cumbersome process, people don't always feel like, you know, can I put this on my CV or can I not put this on my CV? Absolutely, everything that is published in the publications department can go on one CV and can be used for advancement, promotion, go towards tenure. They are essentially comparable to a print publication. The next question that we have is, are either John or myself aware of similar resources regarding nursing school curriculum? So this is kind of an interesting question because it gets at whether or not these things that are adapted to, you know, academic medicine, are they somehow different or not relevant to nursing school curriculum? And I would argue that whereas John and I have said undergraduate medical education, we certainly could very easily call that health education. So bringing some of the competencies that have been developed, learning how to take a sexual history, being able to use the language and terminology of the LGBT community effectively, those are all things that can certainly be adapted to nursing education. The other resource that I would point people to, and you can email me personally on this one, I can put you in touch with individuals who are actively working on nursing school curriculum. So the GLAMA group, this GLAMA Health Professionals Advancing LGBT Equality, they are inclusive of all health professions, including nurses. So if you email me privately, I can put you in touch with individuals who are actively working on nursing school curriculum. And I'm just going to go ahead and put my email address for anyone who wants to email me.
I will go ahead and echo what Kristen said. I do think GLAMA is probably a great resource for anyone who's interested in doing work either interprofessionally or within some of the other health professions. Again, like Kristen said, we've focused a little bit here on medical education, but I agree. Many of these are wholesale exportable to many other health professions and or professions in general. You know, GLAMA Health Professionals Advancing LGBT Equality is really a good organization to further some of the development here from the interprofessional standpoint and to network with other people who are doing that. So, and I'll be happy to put my email out there too as well. So, in case anyone has questions there, I work mostly on the education committee for GLMA, but again, happy to help, especially with people who have questions about curriculum or things of that nature. So,
we do have another question on any success with the creation of outlets for informal mentoring and networking in academic medical institutions. This is more common in non-medical or traditional academic institutions and based in more friendly, accepting regions like UCSF and New York. So there are a couple of different options here. There are certainly, you could argue that an outlet needs to be out. And if you go on to places like the UCSF website, they will have outlets and you know, names will be available online. And this can be certainly intimidating if you're in a less friendly area. What other institutions have done is within the student group or within a faculty group, they have collected names that have been distributed privately, where if they have a website, they can say, if you're interested in this field, please contact us and we can put you in touch with a mentor. So that there is some visible presence to say that we have mentors available across specialties that we would be happy to put people in touch with. So there's a visible presence, but there isn't a name that's being disclosed. What we've done at Vanderbilt is, while we have a number of people who are out, we have asked people if they're willing to be out online and available for contact. So we have sort of an internal list and then a publicly available out list, and certainly our internal list is longer than our publicly available out list. We also, when these individuals are also clinicians, we ask them if they are willing to have patients, LGBT patients, you know, referred to them for LGBT-focused care. And so that kind of internal list for mentoring can also be used for clinical referrals. So these internal confidential lists can be, you know, particularly valuable, where we can say publicly online, we have mentors available or we have clinicians available. Please contact us for more information. All right. So I think if there aren't any other questions, everyone who is still here, again, thank you so much for coming and listening and asking questions. We will have this presentation available for people to watch online. Slides can be used, and then you are more than welcome to share the information from this presentation back at your own individual institutions, and we certainly appreciate your being here today and the opportunity that John and I had to talk to you. We're very excited to do this and really happy that everyone's here.
Tiffany St. Cloud again. Thank you all for joining us. And as Kristen and John mentioned, this is just the first of hopefully many webinars that we will be leading around LGBT health and disorders of sex development in medical education.